All right, I'm back. Let's talk about movement, the role of the peripheral nervous system in movement. Muscle and nervous systems are inextricably linked to one another. Skeletal muscle fibers are voluntary, but they contract only when stimulated by a somatic motor neuron. The upper motor neurons are those of the primary motor cortex, which makes the decision to move and initiate the move, but they are not in contact with the muscle fiber itself. The lower motor neurons receive the message from the upper motor neurons. These are the ones that are in contact with the muscle fibers. They release acetylcholine onto the muscle fibers to initiate contraction. Lower motor neurons are primarily multipolar neurons whose cell bodies are in either in the anterior horn of the spinal cord or the brainstem. The axons are in the peripheral nervous system. The motor neuron pools are groups of lower motor neurons that all innervate the same muscle. They are clustered in the anterior horn of the spinal cord. You have large motor neurons, which the majority of them are large, that are found within these pools. They stimulate skeletal muscle fibers to contract by the excitation contraction mechanism, which we talked about back in the muscle chapters. The smaller motor neurons are also found with these neuron pools. They are innervated intrafusal fibers, a part of the specialized stretch receptors. So muscle, their movement, signal comes into the cerebrum. It is then passed on through the brainstem into the diencephalons, where the signal then goes to the sensory motor cortex. Then the signal is sent downward back to the effector muscles. So we have the upper motor neurons in the premotor cortex select the motor program. The basal nuclei then enable the thalamus to stimulate the upper motor neurons of the primary motor cortex. And then the central nervous system sends the signal to the peripheral nervous system, where those upper motor neurons will stimulate the lower motor neurons. And then here the lower motor neuron is stimulating this muscle to contract. Then the peripheral nervous system back to the central nervous system. We're sending the signal back. And finally, all the interpretation and integration is made to determine what needs to be done at this particular time to this particular muscle. Does it need to contract? Does it need to relax? Does it need to contract fully? Does it need to retract partially? Do all of the fibers need to contract? Do only a few of the fibers need to contract? And all of those decisions are made in the central motor cortex. Reflex arcs, the integration of sensory and motor functions. Reflexes are programmed automatic responses to stimuli. They occur in what is referred to as a reflex arc. It is a three-step sequence of events. These are usually protective negative feedback loops. The reflex begins with a sensory stimulus and finishes with a rapid motor response. Neural integration between the sensory stimulus and the motor response occurs in the central nervous system, either at the spinal cord or at the brainstem. So you have the sensory or the afferent division goes into the central nervous system. Central nervous system then sends a signal to the efferent division or the motor division of the peripheral nervous system, and you have an reflex arc. So the peripheral nervous system detects and delivers a stimuli. The stimuli is then integrated, and then the peripheral nervous system delivers whatever motor response is necessary. Mechanoreceptors in the muscles and tendons monitor the muscle length and force of contractions. They communicate information to the spinal cord, cerebellum, and cerebral cortex. Muscle spindles are tapered structures found scattered among the regular contractile muscle fibers. Between 2 and 12 specialized muscle fibers, known as intrafusal muscle fibers, are within each muscle spindle. These spindles have contractile filaments composed of actin and myosin at their poles. They are innervated by motor nerves. The contractile filaments are absent in the central area of these intrafusal fibers. The primary afferent fibers respond to stretch when initiated. Secondary afferents respond to both static length of the muscle and position of the limb. The Golgi tendon organs are mechanoreceptors located within the tendons near the muscle-tendon junction. They monitor tension generated by the muscle contraction. These consist of an encapsulated bundle of collagen fibers attached to about 20 intrafusal muscle fibers. They contain a single somatic sensory axon that fires more rapidly and at greater tension, or as greater tension is generated with each contraction, and that information is then sent along to the central nervous system. So here's a cross-section of that muscle. There's the structure, the contractile pole. There's that little spindle capsule. There are the myelinated nerves coming in, the sensory afferents, the primary afferents, sending the signal to the biceps muscle that we need to straighten the arm or extend the arm. Reflexes can be classified by two types of criteria: the number of synapses that they have, or the type of organ in which the reaction takes place, either visceral or somatic. The simplest reflex arcs involve only one synapse within a spinal cord or within the spinal cord between the sensory and motor neuron. More complicated types of arcs involve multiple synapses. One with a single is referred to as a monosynaptic reflex. One with multiples is a polysynaptic reflex. The simple stretch reflex, this is the body's reflexive response to stretching of a muscle to shorten it back to within its set optimal length. The patellar or the knee jerk reflex and the jaw jerk reflex are examples of simple stretch reflexes. Each simple step reflex has several steps. First of all, some sort of external force stretches the muscle. The doctor hits you in the knee with the reflex hammer. The muscle spindles detect the stretch. Primary and secondary afferents transmit their action potentials to the spinal cord. In the spinal cord, sensory afferent synapses on the motor neurons then trigger the action potential. The motor neuron stimulates the muscle to contract, and it returns to its optimal length. So we're pouring water into a glass, and before the stretch, after the stretch occurs, and then you'll notice that as the lemonade goes into the glass, the arm goes down, then the signal gets sent, and the muscle returns to its pre-stretch position. Golgi tendon reflexes are polysynaptic reflexes. They protect the muscles and tendons from damaging forces. These cause the muscles to relax, which is the opposite of a simple stretch. When tension in the muscle and tendon increases dramatically, the Golgi tendon organs signal the spinal cord and the cerebellum. The motor neurons innervating the muscle are inhibited, while antagonistic muscles are stimulated and they're activated. Flexion and cross-extension spinal reflexes. These are flexion and withdrawal, involve rapidly conducting nociceptor afferent and multisynapses in the spinal cord, act to withdraw the limb from a painful stimuli. We've all grabbed a hot pot handle and jerked away from it very quickly. Cross-extension reflex occurs simultaneously on the opposite side of the body for balance and postural support, while other limb is withdrawn from painful stimuli. So here we've got somebody who looks like they're walking on the beach. They don't have any shoes on. They stepped on something with this foot, which causes a reaction because of the pain, but at the same time, it causes another reaction to maintain balance on this side. So while this leg is being lifted up in a painful reaction, this leg, the muscles are actually forcing down to maintain balance. Cranial nerve reflexes are polysynaptic reflex arcs that involve the cranial nerves. The gag reflex is triggered when the visceral sensory nerve endings of the glossopharyngeal nerve in the posterior throat are stimulated. You know, if you've ever been unfortunate enough to have one of those tubes put down your nose and through the back of your throat, you find out just exactly how sensitive your gag reflex is. The corneal blink reflex is triggered when stimulus reaches the somatic sensory receptors of the trigeminal nerve in the thin outer covering of the eye. If something contacts your eye, that leads you to blink. That is, you know, the first thing anybody who wears contact lenses, the first thing they have to do to wear contact lens is overcome their corneal blink reflex. Because as soon as you try to stick the contact lens in your eye, you want to blink, and that's why you'll see people literally holding their eye open. You can't see me. Holding their eye open like this to put the contacts in. And that is to overcome the corneal blink reflex. Sensory and motor neuron disorders. Peripheral neuropathies are disorders that impact sensory and motor neurons of the peripheral nervous system. In sensory neuron disorders, the severity depends on which spinal or cranial nerve is involved. Lower motor neuron disorders usually result from injuries to the spinal or cranial nerve or injury of the lower motor neuron body. These generally prevent motor nerves from initiating skeletal muscle contraction. This is a wonderful little thing that we do to test. You can test babies. This is one of the tests they do on newborn babies, but you can also do it on grown-ups. This is what is called Babinski sign when the toes flare up this way. This is actually very normal for a newborn baby because the nerves are not fully myelinated yet. Once you are a couple of years old and for the rest of your life, you should have what is called a normal plantar reflex. You take this probe and rub it up the bottom of your foot, and your toes should curl down. If, however, you do that to an adult and they show Babinski sign, that is a demonstrator of a possible spinal injury or some other motor neuron disorder. Upper motor neuron disorders impact neurons of the central nervous system, so they are not considered peripheral neuropathies. They can result from damage or disease anywhere along the pathways from the motor cortices to the spinal cord. The body's initial response to upper motor neuron damage is spinal shock, characterized by paralysis, believed to be the result from the shock experienced by the spinal cord circuits when input from the upper motor neuron is removed. After a few days, the shock wears off and spasticity often develops, which is characterized by the increase in stretch reflexes, increase in muscle tone, and a phenomenon called clonus, which is an alternating contraction and relaxation of a stretched muscle. Spasticity is likely due to the loss of normal inhibition mediated by upper motor neurons. And Babinski sign also develops elicited by stroking the bottom of the foot. Again, healthy adults will flex their toes in response, known as plantar reflex. We just talked about this a moment ago. Patients with upper motor neuron disorders will likely extend their hallux and splay out their other toes. A positive Babinski sign is often present in infants up to 18 months old and does not signify pathology. Some response in adults is always considered, the same response in adults is always considered abnormal. So as I said, newborns will show Babinski sign, and that is normal. Adults should never show it. Amyotrophic lateral sclerosis, aka Lou Gehrig's disease, involves the degeneration of cell motor bodies of the motor neurons in the anterior horn of the spinal cord, as well as the upper motor neurons in the cerebral cortex. The cause of this degeneration is unknown at present. Many factors will likely play a role. Some of you may have a few years ago taken part in the Ice Bucket Challenge for ALS. There's a former pro football player, played for the New Orleans Saints, was playing for them at the time of Katrina, who I think he recently passed away from ALS. Stephen Hawking had ALS, for instance, so amyotrophic lateral sclerosis. Most common early feature is muscle weakness, particularly in the distal muscles of the limbs and hands. Over time, weakness spreads to other muscle groups as the upper motor neuron symptoms develop. Death typically results within 5 years of the disease's onset. In most forms of ALS, cognitive functions are spared. The patient is fully aware of the effects and complications of the disease. In other words, destroying the body, but the patient needs to keep their mind. Also, although intensive research efforts are ongoing, at this time there is no cure or treatment that prevents the disease progression. And that wraps up the peripheral nervous system. I will pick up later on with the autonomic nervous system and then conclude with the special senses. Have a great Thanksgiving. I will see you later.